All right, so we're going to get started here. My name is Nicole Herndon. I'm one of the speech therapists at the Fixel Institute. And this is Bryn. She's another speech therapist. She's also doing her PhD at UF, so she'll be my co-presenter today. We're going to be talking about speech and swallow in Parkinson's disease. And while these two non-motor symptoms of Parkinson's disease share the same mechanisms, they serve separate goals. So here's an outline of what we're going to talk about today. First, we're going to talk about the anatomy and physiology of these mechanisms, and then talk about speech and swallow changes in Parkinson's disease, the evaluation, treatment, and strategies that can help you communicate and help you swallow. We'll conclude with a summary slide, and then we'll take questions if we have time. So the anatomy and physiology of the shared mechanism here is the speech system. So there's 4 subsystems for speech: the respiratory system, your lungs; the laryngeal system, or your phonatory system here; your articulatory system, so your mouth that shapes the sounds; and then your resonatory system, giving it a certain tone. Sometimes it's going through the nose for ims, ins, ings. That would be like a nasal resonance. And so with these, you can see we have the mouth, right? The tongue, the lips, the teeth. So that would be our articulatory system. Down, let's see, can you guys see my cursor? No. So down with the tube that's in the front, further down, is the airway leading down to your lungs, and then actually right behind it's your esophagus. And then up through the nasal cavity, that's going to be your resonatory system. Speech changes that typically occur in Parkinson's disease can impact up to 90% of those with PD. And typically it presents as a hypokinetic dysarthria. So if you think about Parkinson's disease as being hypokinetic, hypo meaning reduced, kinetic meaning movement, that's why speech is impacted. So some of the features of hypokinetic dysarthria are reduced breath support for speech, resulting in reduced loudness; a hoarse or breathy vocal quality; short rushes of fast speech or faster rate of speech generally; reduced clarity; more of a monotone inflection; and stuttering. All right, so Bryn's going to talk about this next slide.
Yeah, so why do we even have these speech changes that occur in Parkinson's? So we know the clinical hallmark features of Parkinson's are bradykinesia, so slower movement; rigidity, so the tightness of the muscles; and then tremor and postural instability. So really we get our speech symptoms from the bradykinesia aspect and rigidity aspect as secondary causes of, speech is a secondary symptom of these 2 symptoms. And how that manifests in our breathing is that if you think about the lungs, right, they kind of stretch like a rubber band. They have this rubber band effect. So when you breathe in, if you notice on our graphic here, you are expanding your lungs. So inhale, and then an exhale reduces the lung volume back to rest size. So you need musculature to open up your lungs, because our lungs are attached to our rib cage and the muscles around them. That's how you're able to move them. There's no actual muscle in the lungs. So if your muscles of your respiratory system are more rigid, they're not moving as much, then you don't take as big a breath in, and you don't have that power to then flow your air through your vocal cords to create a nice big loud voice. So generally, over time, we see a quieter and quieter voice as a result. And in terms of abdominal breathing, that just means that it's the exhale and the airflow you get from that is very passive. So it simply happens just from the elastic recoil of the lungs going back to their rest position. But we notice that people with Parkinson's oftentimes use their abdominal muscles to kind of squeeze the air out instead of just starting with that nice big breath in that naturally flows back out. So you sometimes also get that hoarser vocal quality as well. And Parkinson's is a very slow-moving disease, so these changes are very slow over time, and that can make them harder to perceive. So if it's, gradual couple decibel increase or decrease over the year, that's very hard to notice over time. It's kind of like watching grass grow. You know it's growing, but you can't really see it. So that is why we have these check-ins that we recommend every so often with a speech therapist to have those more objective evaluations over time, because it can be hard to notice that decreasing slowly of the loudness of the voice and faster talking, those kind of hallmark characteristics. So, oh my Lord. All right. So how do we even evaluate for these changes?
All right. Well, we listen to you talk. So we give you different tasks to evaluate the different subsystems for your speech, for your voice. And some of these tasks might seem unusual to you, but I promise they serve a purpose. And this is something, like Bryn said, we like to see you every so often so we can track you over time. So what we can do is say, oh, we're starting to see this area change, and so let's get ahead of any greater changes. It's easier to prevent further change than it is to work backwards. So speech treatment, there's a few things that we can do. Remediation, we can do some exercises, trainings, and programs. We can compensate for it. So we can use like a voice amplification device or a microphone to a speaker to help you be heard. Augmentative alternative communication is another form where you can use a device or you can point to pictures that help you communicate and that person who's your communication partner understand your needs. And then lastly, communication strategies with a speaker and a listener. So we know communication, there's both a speaker and a listener, and it goes both ways. It constantly is switching throughout. So we can't just blame the breakdowns on just the one speaking person. We have to figure out ways for all of us to adapt.
All right, so just to sort of illustrate what we're talking about here, I want to first emphasize the difference between like thoracic breathing with your kind of with your chest versus diaphragmatic breathing, which is the type of breathing that we prefer. So I want you to put one hand on your chest and one hand on your stomach, and I want you to take a big breath in. Okay, did you feel your hand or your which hand did you feel move? Your chest or your stomach? Anyone? Your chest? Yeah, chest? No. All right, we got to get the stomach moving then. So this time I want you to take another big breath in, and I want you to really focus on filling your balloon so your diaphragm pushes out when you breathe in. So it's like a movement with your diaphragm pushing out, and then so if you do yoga or Tai Chi, it's that kind of breath. Mm-hmm. Yeah, so very good. So this time I want to do that same thing again, but then on the exhale, I want you to nice loud voice. Today is a beautiful day with all the air flowing out on the exhale, nice and loud, like your words are riding a river, and the river's your breath. Okay, big breath in. Today is a beautiful day. Nice. That was good and loud. Yeah. So that kind of loudness, that intensity, that kind of like performance voice is the kind of voice we want to cultivate in people with PD, because we know these slow changes happen over time with volume. So these kind of preventative measures help maintain voice for long periods of time. And we rarely ever see people with PD like completely lose their voice. This is not something that's unstoppable or inevitable. It's simply a different way of breathing and a different way of speaking to start practicing.
And some of our patients will say it's more effortful to get louder, and that's because they're probably engaging those abdominal muscles, which is active muscle, versus just breathing in and taking advantage of that recoil, the rubber band. So something to think about.
Mm-hmm. And then in terms of articulation, we, as we mentioned earlier, we often see that faster rate of talking, not as often as just a quieter voice overall, but sometimes we do see like faster rate of speech that can make your speech a little less clear. And that is for the same reason as the breathing. So the muscles in your jaw and your tongue and your lips get a little more tense, so they don't want to travel as far as they used to. So you're able to talk faster and faster and faster because you're not going as far in your mouth to hit the speech sounds. So in terms of trying to prevent that and a compensatory strategy for that, we often recommend something called over-articulating, which is basically kind of like how a newscaster talks, where you really put extra emphasis into moving your tongue and your jaw and your lips to really hit those speech sounds and really have that nice, clear, articulatory precision.
Yep, so we want the top one and not the bottom one. The bottom one represents hypokinetic movement. So if any of you guys have handwriting changes, starts off bigger, gets smaller, same thing can happen with the movements of the mouth. So as you're talking, they get a little bit smaller, and then you can speed up and it's a little bit less precise. Something like that. All right, so let's talk about some speech treatment programs. You've probably heard of at least one of these. So LSVT Loud, Lee Silverman Voice Treatment, is 4 sessions a week for 4 weeks. And they give you home exercises to carry over during the program, and then you have to do maintenance exercises afterwards to maintain the benefit. So oftentimes I'll have patients say, oh yeah, I did loud. And I'll say, do you continue to do the exercises? And they'll say, well, no. So it's really, really key that you continue those exercises. We're trying to fight progression of Parkinson's disease, and the way to do that is maintain your exercises. So LSVT Loud has been shown to increase loudness, intonation or inflection, improve vocal quality and clarity, and it can decrease speaking rate. Another program is Speak Out by the Parkinson's Voice Project. This is about 12 therapy sessions before you kind of graduate and go to the loud crowd or the group therapy. And something that I like about this is it does incorporate cognitive exercises too. So it's always a good thing to be working out your brain. Once again, they have you do home and maintenance exercises to maintain the benefit and generalize from the speech therapy room into, the house or where you're actually communicating. And then they've shown that it increases loudness and perception of vocal function is improved. Another kind of treatment program that's on the market is the Speech Vive device. So you wear it over the ear, kind of like a hearing aid, and it puts some noise in your ear, and it uses a lumbar effect to have you get louder. So if you imagine at a cocktail party, it's a little bit louder, you naturally use the lumbar effect to increase your volume. So that's what it's trying to target. It puts that multi-talk or babble in your ear as you start to talk. So it's trying to get you to get louder. So it can help with loudness, length of utterance, clarity, and intonation. So far I've heard the VA will cover it. I think they're trying to get some insurance, like Medicare coverage. They're in the process of it, but if you're interested, you can reach out to them.
Yeah, so, and you can also just change the way you talk with people and the way people talk with you to kind of help improve your communication effectiveness. So you probably have a primary conversation partner. They probably live in the house with you or something like that. And there's different things you and your partner can do to help. So being in the same room together, facing each other, is very helpful. So like you get the facial cues right, but then you also, if you're yelling at each other from across the house, yeah. So and also if you have reduced background noise, so obviously in like a restaurant or something like that, it's going to be harder to understand people. Moving to a more private location, turning off the TV, things like that can be helpful for improving communication efficiency. Getting the attention of the person you're talking to before you start talking can help save you some time. So, hey, so-and-so, they're looking at you now, and now you can enter into what you're about to say so that you don't have to like recap the first half of what you said because they weren't yet attending to you. Providing context can be helpful, so starting with the subject. So, for dinner, where would you like to go? So just starting with the priming them almost for the rest of what you have to say, because it makes it easier, even if they can't hear you, to kind of infer what you're saying or fill in any blanks that they have. And also, just as a listener, if you tell your partner, well, I heard this, what's the rest of what you said, then that creates less work for the conversational partner in repeating themselves often. All
right. Yeah, and another thing that I just want to bring in is occasionally I'll have a significant other, a family member say, well, they're just lazy with their speech. And it's not laziness, it's the Parkinson's disease. They don't know that they're so quiet. And so when, they're talking, they think that they're loud enough, right? That awareness has changed. And so when they get louder, they might feel like they're shouting at you, even though you're saying, no, now I can hear you. So, just be cognizant of that. It is not laziness, it's the Parkinson's disease creating some of those changes. So you might say, well, Nicole, if you're talking about these key Parkinson's features that medication help with, will it impact speech? And it's really inconclusive at this point if it helps speech. I've had patients anecdotally tell me that they feel like their speech has improved. Maybe it's a rigidity, but so far research hasn't supported that. And what about deep brain stimulation? Well, dysarthria or speech changes are a non-motor symptom. So DBS is really good about capturing and improving those motor symptoms, but not so much the non-motor symptoms like speech. Same thing for swallow. And two of the locations that tend to be targeted for Parkinson's disease and their symptoms with DBS is the STN, the subthalamic nucleus, and the GPI, the globus pallidus interna. And same thing, there's ongoing research trying to figure out if it's better, worse, if it stays the same, and we just don't know enough yet. But ultimately, we know that DBS is brain surgery. So when you put something in the brain, there can be effects there. And sometimes we also see that programming can influence it. So they put the leads in your brain, and it stimulates that specific location, the STN or the GPI. But if it goes beyond those boundaries, there's some speech and swallow tracts there that can be influenced by the stimulation, leading to speech or swallow changes. Fortunately, those can be reversed by just changing the programming settings.
Yeah, so we know y'all are about to go to lunch. So you can think very deeply about your swallowing each time you swallow during your meal after this lecture. More information than you ever want to know about swallowing. There's 3 phases to it. And you'll see here that we have the same image we had to talk about speech because the 2 mechanisms overlap quite a bit in the structures that they use. So we have the oral phase of the swallow, which starts up here with the tongue and the mouth, obviously, and then it moves back into the pharyngeal cavity or the throat, and then we have the esophageal stage, which is in your esophagus. So as speech therapists, we can help and evaluate and diagnose problems in the oral phase and the pharyngeal phase of the swallow. But if you do have esophageal symptoms like reflux, hiatal hernia, whatever you got going on, that's going to be GI, gastroenterology, to do a more thorough examination of your esophagus, because we'll show you earlier, we can really only see these 2 structures. So the swallowing mechanism is a very delicate and complicated process that has developed over time. So we can see food enters your mouth in the oral phase. So that's when you're chewing food up, processing it, getting it ready to be swallowed. And this part at this point is still volitional. It's under your control, how fast you chew, well, to a certain extent, and how much you chew it, things like that. And then once it gets to like the back of the tongue, that's when it starts to transition to a non-volitional task or an automatic task, reflexive task. And we're in the pharyngeal phase now. So pharynx is your throat. So if we see the green blob of avocado, I'm calling it, it is in the back of your throat now. So the base of the tongue, this big structure in your mouth, is going to meet with the muscles of the back of your throat, and they're going to squeeze the food down to your esophagus. And as part of that squeezing, you get the folding over of your epiglottis over your airway, because you'll notice that these 2 structures are very close together. The entrance to your air hole is very close to the entrance to your food hole. So a lot of the reason why this mechanism is so complicated and delicate is because there's several precautions to try and protect your airway from food going into it. Of course, everyone aspirates, has food go into their airway every now and again. You cough it happens completely normal. But in Parkinson's, we can see more of that more often. At the end of the swallow, we have the food enter the esophagus and hopefully make its way down into the stomach. And at that point, the airway is going to open back up and you're going to exhale. So generally the pattern is exhale, swallow, exhale, because if you think about it, if there is anything hanging out in your throat after you swallow, then you don't want to breathe that in. So you're going to exhale. So if we try it now and you just swallow your saliva, you'll notice you exhale right after.
You can tell we're true swallow nerds by all of our information here. Sorry, guys. So what happens if swallowing isn't working well? Well, that can present as dysphagia, so difficulty managing food or liquid once they enter the mouth. So if you're bringing the spoon up or the fork and that's where your problem is, that's more feeding, that's occupational therapy, but sometimes you can have both. And consequences of dysphagia are why we're really concerned about it. So it can cause malnutrition or dehydration, choking, aspiration pneumonia, so material that you're swallowing or material from your stomach, like reflux coming up and going into the airway, causing an infection, taking longer to eat a meal, which kind of goes along with the malnutrition and dehydration. If it takes you longer, you're going to be burning more calories typically, and drooling. So swallow changes in Parkinson's disease can impact up to 80% of those with PD. And it kind of varies in severity. So speech and swallow severity don't always track the same. So someone might have a moderate dysphagia, but speech is relatively intact. So we can't just align the two. But it's not always that obvious, right? So it's often underreported and underrecognized. And part of that is there's been research by our colleague, Dr. Karen Hagelin, that shows that cough responses diminished or absent. So sometimes when material goes the wrong way, those with Parkinson's disease don't sense it or they can suppress it, so then they don't cough. Whereas for all of us, if it's us without PD, if something goes down, hopefully we have that cough response to eject it out. And dysphagia symptoms can present as coughing more frequently with foods or liquids, difficulty swallowing pills, sensation of food or pills sticking in your throat. And we also have to remember that cognition plays a role. So if someone's impulsive, big bites, big sips, distracted by watching TV, something like that, that can also influence the swallow. So why do swallow changes occur in Parkinson's disease? We don't know. So it's so complex that we haven't really delineated what's going on. We know that the typical features of Parkinson's can contribute. So going back to those key clinical features, so we think that the bradykinesia and the rigidity play a role. So when you think about it impacting muscles as Parkinson's disease, we use so many muscles for swallowing. But there's also some theories that brainstem dysfunction, your swallowing centers are in your brainstem, and some muscle atrophy can play a role. And then we also know that there's age-related changes to the swallowing mechanism. So sometimes when you have those age-related changes with something else on top of it, then there's a bigger impact.
Yeah, so how do we even assess your swallow, right? And there's a few different ways. So the first way is called a clinical bedside swallow evaluation, and that is basically based on observation. So we are watching you swallow just as an observer, and from that we can glean a few things like the general strength and range of motion of a few of the muscles and important components of the swallow mechanism, and then also just general symptoms of aspiration, like throat clearing, coughing, kind of gurgling noise, anything like that, just as kind of clues to the puzzle. But the gold standard for swallowing evaluation and the best way to diagnose a swallow problem is through an instrumental evaluation, either through what's called a modified barium swallow study, or video fluoroscopy, or fiber optic endoscopy. And generally when we're evaluating swallowing, we're looking for two things. So first is safety. So that is whether or not there is food or liquid going into the airway. So if there is, then it can do one of two things. It can either penetrate, which means it goes to the top of the larynx. So the larynx is the opening to your trachea and the opening to your lungs. So if food or liquid penetrates, then it will enter into the larynx, but hang out above the vocal folds. So it has not entered into the trachea, has not entered into the lungs. Oftentimes it will pop back out, or it'll cough and clear it, one of the two. If it does, food or liquid does go below the vocal folds, then that is aspiration. Sometimes you cough and clear it. Sometimes it goes into the lungs. And aspiration is a benign event in and of itself. Aspiration of water is, at least. So, like, there's nothing inherently unhealthy or inherently problematic with aspiration, because especially if it's clean water, your body will get rid of it on its own. But there can be secondary complications to it, and that is what we're trying to avoid. And there's several different ways we try to avoid complications if you are aspirating. Second thing we're looking for is efficiency. So that is just basically, is there food or liquid hanging out in your throat after you swallow? So this is the process for a modified barium swallow study. You may have had one done at Fixel. This is how we evaluate swallowing
We just don't do it on animals, though.
We have not done one yet on a gator. I'm waiting for approval. No,
It would be interesting, though, yeah?
Right? Yeah. I don't know what their larynxes work like. So basically, in this process, you are sitting where the gator is. This is a C-arm X-ray machine, and we are taking an X-ray video of you swallowing. So it's non-invasive. It does not hurt. You don't have to do anything special leading up to it. It takes usually about 15 to 20 minutes. We are having you swallow different consistencies of barium, which is an element. Barium is white. It does not allow X-rays to penetrate through it, which is why we're able to see where food and liquid are going in your throat. Doesn't taste too bad. Don't worry about it. It's easy. And if we are able to see a problem on your swallow study, then we are actually able to troubleshoot and try different strategies while you're sitting in the chair to make sure they work.
All right, so I'm going to show you guys some videos in a second on the next slide. So I just want to kind of talk about some of the anatomy that you might see. So right here is the base of the tongue. So it's the bottom part of your tongue as it enters the throat or the pharynx. Right here is your epiglottis. So it's a curly piece of cartilage that at rest forms a natural pocket, the vallecula, and as you swallow, the cartilages come together and that epiglottis folds over to help protect your airway and keep your swallow nice and safe. Up here is your soft palate. So it's going to elevate against the back wall when you swallow, because we don't want material going up and into our nose and have some nasal regurgitation. It also helps generate the nice pressure that we need for swallowing. Here are the level of the vocal cords, and then here is the laryngeal vestibule. So Bryn was talking about penetration of material. So here we would see it enter the laryngeal vestibule above or to the vocal cords, and that's considered penetration. If it goes below those vocal cords into the trachea, that is when aspiration occurs. Here's that back wall. So when we're referencing, the tongue base touching that back wall or material being pushed down with a pressure wave, that's what we're talking about. And then the upper esophageal sphincter is just the entrance to your esophagus. So that's kind of the boundary between your pharynx and your esophageal stage of your swallow. All right, so this is me swallowing, so I'm just going to play it here. I think if I press, yeah. So I'm just swallowing different consistencies. That's thin liquid. Here's a thicker liquid. Here is a pudding consistency. And lastly, I'm going to chew up some cookies and then swallow those. All right, so now I'm going to show you an unsafe swallow. So this patient is going to aspirate. So remember, we're looking for entering the air tube in the front and going below those vocal cords. So you can see it there. And it doesn't appear to have, oh, there's a little cough response there. Mm-hmm. Looks a little weak. It's not effective in getting the material out. And then an inefficient swallow, so some residue that this patient has in the pharynx that's remaining and just not really getting that nice pressure generation. The muscles aren't touching like we would like to see. So you can see the multiple repeated swallows, and if you think about it, that's quite fatiguing. So here is an example of FEES, flexible endoscopic evaluation of swallowing. So this is one where it is invasive. They stick a small camera up through your nose, and they're going to be looking above at your throat and your voice box. And it only assesses the pharyngeal stage of the swallow, so they can't see the oral phase. But one of the benefits is that they can give, during this exam, they can give you real food and real liquid. So if there's a certain food that you're having more difficulty with and you want to see what's going on, this would be the study for that. We can also see saliva, whereas we can't see that on the video fluoroscopic studies. And we can also assess the anatomical features of the larynx and pharynx. So we can make sure, you know, that there's not any structural changes, redness, things like that. So it gives us that vantage point. So here, I think it's a little blurry, but you just need to know the basics. So up at the top is the back of your throat. At the bottom is the front. So at the front, we see the epiglottis, and just beyond that, off the picture, would be your base of your tongue. And then you can see the two white V shape. Those are your vocal cords with the airway, the trachea in the middle. Just behind that would be the entrance to your esophagus. And then to the side, we have these lateral channels that kind of funnel material into our esophagus, trying to get them around the airway.
This is an aerial view of your pharynx, whereas the view we had earlier was a lateral view. Mm-hmm. So just a little different.
All right, so this is one of my former students doing FEES. So just for reference, you see the epiglottis, and then you see that white material going down. That is what she's swallowing. It's hanging out just on that base of the tongue there. And it's going to be a little bit blurry because she does have saliva, but you can see how we can see true coloring of the structures and kind of look at those. So I'll play it here.
So they just swallowed, so
Mm-hmm.
that's why.
Yeah, so it's a whiteout period when they swallow, and then they can look at it afterwards.
We give her a little bit of time.
Swallowed again.
And as a true swallow nerd, she was trying to aspirate. It didn't work.
It's very hard to make yourself do.
Yeah.
So there's different ways we can treat swallow problems if we do find them. There's oftentimes very specific problems with the swallow, and if it works out, then we can train certain muscles in the swallow to be stronger if it's appropriate. We can also do compensatory strategies. We'll most often recommend compensatory strategies, so that looks like alternating bites of food, sips of liquid, taking smaller or single sips and bites, swallowing again after you've swallowed once, doing a chin tuck while you swallow, taking your pills and puree, all that kind of stuff. And it all depends on exactly what the issue is in your swallow. There's no one catch-all swallow plan, swallow regimen to do. It's very much tailored to what is specifically going on with your swallow. And then if necessary, we can also modify your diet. So you just eat and drink different things or avoid foods and liquids that are specifically difficult for you to swallow.
And I just want to jump in really quick and say, we don't know what's going on with your swallow. So we really need that instrumental evaluation to figure out how these compensatory strategies or diet modifications help you, because everyone is different. So it's not, like Bryn said, not a chin tuck doesn't work for everyone. Thickening liquids doesn't work for everyone. When we really have to consider quality of life and what you as a patient and what your family want to do. So it's a discussion. It is not, and it's a recommendation. It's not a hard, steadfast rule of you must drink your thickened liquids, no ifs, ands, and buts. So.
Yes, we also have a device called an EMST, Expiratory Muscle Strength Trainer, and it has shown in research benefits for speech, swallow, and cough, interestingly. Speech, I would say, is the most minimal. And so for this one, it is strength training the expiratory muscles. So you have a set of muscles for inhaling, and you have a set of muscles for exhaling. So this device, you are breathing against a resistive load. So you take a big breath in and you hard and fast into it, and that contracts the expiratory muscles like you're going to the gym. That's 1 rep. And it helps with speech because you're getting that increased airflow, right? That increased output for your breath. It helps with cough because we need those strong airflows to help produce a nice strong cough if anything does happen to land on your vocal cords. And it also has shown benefits for improving certain aspect of swallowing. So if you hold your hand to your throat and you swallow, you'll notice your Adam's apple rises and then comes back down. And that, if you notice, when you do like a hard, like a sound or like a cough, like a then you'll feel that same movement in your larynx, and it's training that movement. And so it can be helped, this device you can get through your speech pathologist, either at Fixel, us, or your home speech therapist. So oral care is 100% the best way to prevent problems with aspiration. So like I was saying earlier, aspiration is a benign event if your mouth is clean. So really what the trouble comes from is if there is bacteria in your mouth, the food then grabs onto that and then carries it down into your lungs where bacteria can then colonize. But if your mouth is clean, then it's just food and liquid going into your lungs, which is much easier for your body to get rid of. So absolutely 100% brushing your teeth. If you are diagnosed with aspiration, then it's better to brush your teeth before and after you eat. But keeping up at least 2 times a day brushing, flossing, mouthwash is not enough. Even if you have dentures, you have to scrub your mouth because bacteria doesn't get off with just mouthwash. You have to you need that friction. And of course, keeping up with your dental appointments. You can also have excess saliva as a person with Parkinson's disease. That's another speech symptom, swallow symptom. And what's happening there is your salivary gland is not different, it's not overactive. Simply, you are swallowing absent-mindedly less often. So typically, we are swallowing our saliva about once a minute. But in Parkinson's disease, the body doesn't like to do multiple things at once. So you're swallowing absent-mindedly less often, so you end up with more saliva in your mouth. A few tricks: taking sips of water throughout the day, chewing gum or candy or something like that to help stimulate those swallowing reflexes. And also, there's other pharmacologic options if you have really bad drooling or something like that.
Medication or Botox injections.
Yes. Dry mouth can also alternatively be a symptom, and that can be due to a variety of things. It can either be secondary to a medication you're on, or it can be a symptom of autonomic dysfunction. And the best way to manage that is frequent sips of water to help alleviate that symptom, lozenges to help kind of stimulate that saliva production, limiting or removing alcohol-based mouthwash from your routine because alcohol is drying, using biotin products, and if it's really bad, there's synthetic saliva is available.
All right, so some take-home messages here. So we know that speech and swallow changes are very common in Parkinson's disease, but the severity is different amongst each individual. Typically, disease duration does indicate it gets worse over time, but it kind of varies.
Yes, and we also know that speech changes include reduced loudness, clarity, talking faster, and monotone inflection. Those are the big ones.
And then swallow changes may include coughing with foods or liquids or sticking of food or pills.
And we recommend you get your evaluations done for speech every 6 months. For swallow, every 18 to 24 months. Unless you're having symptoms, then please come in sooner. But that should be generally your check-in timeline for speech and swallow.
And lastly, we know that there are speech and swallow exercises and strategies that can be implemented to help manage these changes and hopefully slow the disease progression. So we are really big on prevention and maintenance of where you are versus that progression.
Here's our references. Lots of references. Here they all are. Thank you so much.
All right.
Thank you.